Yeah, Dr. Professor Peter Schwarz, Professor of Prevention and Care of Diabetes, specialist in internal medicine at the Medical Faculty Carl Gustav Karus and Habilitation Center, Habilitation in Internal Medicine. Peter Schwarz has 252 peer-reviewed publications, a grand accolade. His citations include 15998 articles, so much, without self-citations and are represented by Hers Index 52. He has written 42 book chapters. Peter Schwarz, we are more than happy to share screen with you. Peter Schwarz has invited to more than 350 presentations to peer-reviewed internationally established conferences, and his lecture will deliver all kind of wisdom which he has got in this field. Next to Peter Schwarz.
This is a great honor. Thank you very much for your introduction. It's always interesting to hear someone else introducing yourself, and so it makes me a little bit shy after your presentation. But on the other hand, it's a great honor to be here and actually to speak from Germany to India in this also a little bit difficult times for any one of us. And I liked the previous presentation a lot because it was highlighting the power of digital tools for patients with type 1 diabetes. And what I would like to do is adding another top, because I'm totally agree with this previous speaker, but I would say the power of digital tools differentiate how good they are able to help our patients through their lifestyle. And if you talk about lifestyle, we are directly also in diabetes prevention, because I see a big future, actually a disruptive future in the diabetes sector for digital tools. And again, I thank for the introduction, and I would like to highlight the last line, because I'm currently chairing a large working group from our European Diabetes Association and the International Diabetes Federation with the idea to push the development and the implementation and also scalability of digital tools for our diabetes patients, but also diabetes prevention. And we want to push this actually from the not from the physician's mainly point of view, from the patient point of view. And this is something else what I would like to add to the previous presentation. COVID-19 is driving all of us. We actually have very, very high numbers in the state, in the southern state of Germany currently. And it changes a lot of our views onto our practical medicine, but it has also changed our view on the use of digital tools. Because if you see here 550 people from Facebook, all the red ones developed diabetes through their lifetime, but there are some green ones, and the green ones were able to use digital tools empowering to better self-management and help them to avoid diabetes from developing. And this is what I would like to go through with you. There are big new opportunities, and the previous speaker actually has mentioned all of them. There is a lot of mobile devices now available all over the world. There are a lot of applications who help the people in their lifestyle, in quality of life, to empower the people for better self-management and assisted decision-making. And I think this is a big opportunity for diabetes care or the care for any patient with chronic diseases. But I think they only meet this criteria if they are able, on one side, to inform the patient, and this is what we just have heard from the previous presentation, by giving a feedback, by storing the data, by analyzing the data, using artificial intelligence to present the data in a different way. But this is not all. They need to be able also to help the patient, to motivate the people to change lifestyle. So using digital technology to motivate people at the end to meet the third criteria, to change behavior. Only then I think they will be successful. We know it from all of us that if you download an app on our smartphone and we don't like the app within the first hour, we delete the app again. So the patients are also brutally honest in the digital field. If they don't like what they have on the smartphone, they will not use it. If the physician tells them to use it, but they don't like it, they use it in the adherence is low. So this is a challenge for the development of those digital tools. And another challenge applies, and this is ADA and EASD saying, what is our role as healthcare professionals? We should be knowledgeable about this digital helps us and their strengths and weaknesses. We should know how to use them in medical care and prevention, and we should use the data for our daily work. And if I ask you, all the people attending this conference, are we aware about all these apps? Are we knowledgeable about all these apps? And I think most of us will say, no, we are not. Sometimes our patients are better educated in using these apps as we are as physicians. At least this is the experience we have in Germany. Because there are a lot of different views on digital tools. And this is, of course, and this in my mind is the most important. What is the user saying about this digital tool? Is it a bolus calculator? Is it an app helping to improve physical activity or dietary behavior? The user, the patient first decides, do I like this app or not? Then this was mainly what we just have here in the previous presentation. What is the healthcare provider view? And then the patient view comes. But the patient first is a user and is not first the patient. Then the peer group, behavioral aspect, and other aspects. And I'm sure there are many aspects we even don't know yet. In my mind, as better we are to meet the intuitive need of the patient, as better we are in pushing the patient or helping the patient to use the product and change behavior. And this means, or leads me to the question, how are we changing behavior? Because we are not different than any of our patients. And if you look here, if a patient has cancer or pneumonia, the patient normally will follow us, what we say as a physician. If you talk about diabetes and obesity, we as physicians are out of the game in driving or directing the patient lifestyle. The patient will trust us and he will follow us what we recommend him, maybe for 1 or 2 days, because then there is a more powerful group taking over this reflection, and this is the patient peer group. So the peer group of the patient is more powerful in terms of lifestyle of the patient than we as physicians are. And what is driving the patient in changing behavior? It's purely quality of life. So if we apply this, then this means using digital tools, they must be as good as that they are used in the peer group, that the peer group is supporting this, and that the patient feels within 1 or 2 days that it's improving his quality of life. And this is a big challenge, but I'm very sure we can meet this challenge. If I then say apps should be able to help the patient to change behavior, we must study how does behavior change work. And here you see a model we have developed in a large European initiative. There are 3 main blocks. This is motivation, action, and maintenance. But each of these blocks has different stereotypes of patient, different circumstances of what is needed. But there are technologies or techniques from psychosocial therapy we can use, like motivational interviewing, reflective listening, SMART goals, importance ruler, and so on. We can use to guide the patient through this change of behavior. This is easy if you do it from eye to eye with the patient. But is this maybe a chance for digital tools to apply this technology, to apply behavioral science techniques into digital applications to help the patient to change behavior? And I'm sure if we meet this criteria, we will be successful in prevention and improving care of our patient for diabetes. In my mind, digital support means not that the patient has a problem and he uses digital tools and the digital tools is doing something. We should rethink the strategy and say, it's our goal to support our patient digital. And so the support is the main thing for me in this sentence. It's not that it's digital. Digitalization is only a technology, but what is the quality behind the tool? It makes a difference. That means we have to act innovative and we have to think about acceptability for our patients. As I said in the beginning, the patient is brutally honest. He's downloading an app, he's testing the app. If he don't like it, he's deleting the app. And we should think about how can we make those tools as acceptable by addressing the need of the patient for our needs in diabetes care. We are often talking about digitalization, but we mean telemedicine. We mean downloading data from a glucometer, from an insulin pen, from other sources, and mirroring it back to the patient in an aggregated manner. This is banal telemedicine in my eyes, and this is actually old-fashioned digitalization. But if we add feedback and intervention to this data, for example, using artificial intelligence to make use of the data, to give the value to the data, then we can translate this into better care. In my mind, this is mHealth as mobile health and smart health in applying this data for better quality. So how can digital innovation help the patient to improve self-management? And we have asked about 4,000 patients, and this were the answers the patient gave us. Of course, some of them mentioned interconnection with diabetes tools, but other mentioned gamification, other mentioned decision support, interaction with Facebook and other social media, and those were often more important than the pure disease-driven applications. So how can we make use of this for us? If we discuss the pros and cons of apps and digital tools in diabetes care, following what the WHO is saying, there are a lot of pros in terms of motivation, safety, giving a direction or improving adherence in diabetes care, but also supporting independence of self-care for the patient. But there are also downsides for the app, and we should not forget that the literacy of using the app is very important. And this is not only diabetes literacy, it's also digital literacy. So often the elderly can learn from the young people in terms of literacy, but this is an important point of acceptability of digital tools for our patients. If you go through, this is number one in my mind. The apps can help to support the patient in changing lifestyle for better diabetes care and prevention. And this is reducing the risk of prediabetes. It's so simple as if digital tools is supporting the patient to be more physically active or change dietary habits, it really can prevent diabetes, and it can be more successful than what we have learned from the big diabetes prevention trials. If we move into other aspects, adherence to medication, adherence to a lifestyle, adherence to a new learned habit can be very powerful by using this aspect. And cost is becoming an issue. Good apps, some of them are totally free available. Sometimes we don't know about the quality of these apps, but it can be very cheap in costs for patients, especially vulnerable minorities. But it also can be the opposite. We are just experiencing in Germany that we can prescribe apps as physicians, but they are sometimes 3 or 4 times more expensive than some medication. Finally, interaction with a healthcare provider. This is what we would have loved if we would have had it in the Corona pandemic, having contact to our patients through the pandemic by using an app. Geographical barriers and psychological aspects I already have mentioned. So what are potential barriers? Yeah? Electricity, literacy, stigmatization are points we have to be aware. So a digital tool is not meant to be applicable for any one of our patients. I think we need a bouquet of different tools addressing psychosocial needs of our patient. So there is a ladder of where one step builds on the other. Monitoring, it may start with it may go ahead with some disease-specific aspects and additional features driven by the need of the patient. Here are examples. And if we look at the number one, it's behavior change. So if an app is sustainably valuable for diabetes care or the care of people with chronic diseases, it is only then if it's addressing a behavior change for the people. Or, for example, we had this example, this self-monitoring of blood glucose. If it helps the people to drive decision or helps the people to adhere to a therapeutical behavior. So I would like to give you a small example how digital innovation can help. We push our patient or we force our patient to measure glucose, but we random or seldom ask how often the patient understands the value which is coming out. And there are studies showing that 70% of our patients do not understand what means the value of glucose level, and they are not able, 54% are not able to correctly react on this glucose level. So there is a difficulty in literacy in understanding the value. And can digital technology help? And this is one example with a smart-like technology, like the glucometers, will give the glucose value as in color. Do you see the pattern here? Does this help? Or do you see the pattern now here? This is actually easier. This is what our patient is seeing. Does this help? Or this? Or maybe this? This is preprandial. Do we actually need the numbers? Or is it enough like this? Or like this? This was a very simple example, which is working in some patient groups very actually ideally, that we switch away from educating the patient to use the numbers and to act on the numbers, translating this into colors, but make the colors actionable, because the traffic light system, it's an actionable color association all over the world. You have to stop, you have to go, you have to wait, you have to be aware of, and highlighting the glucose values in making it actionable for the patient to walk, to drink or to eat something because of a hypo, or to spoil the patient as he is in an excellent frame, would be the right way to go ahead. So the colors in this might give a meaning to the numbers, and this was only possible by connecting apps to the glucometer. So you measure your glucose and your app tells you how good you are or what you should do. And this is extremely helpful for many patients. It's about 38% of the patients are directly improving their lifestyle, and this can be translated into a lowering of A1C by about 1.3%. And this is shown here. You see how lifestyle can reduce A1C, how our glucose medication lowers A1C, and at the end you see how our digital interventions can lower A1C. And we see the last column is about the same as good as lifestyle intervention, and this were the newer digital tools developed, and this is the power of digitalization. If we are able to help the patient to change lifestyle by using digital tools, then they will be valuable, then they will have an added value for diabetes care and prevention. And how does this work? I mentioned already the different stages of readiness to change lifestyle. What we are driven as physicians is to understand the morbidity of our patient, but what we have to learn is to address more the intuitive need of our patient. Now imagine this three-dimensional structure. We can position each stereotype of patient in this network. And if we bring this together with all the digital tools and data available for our patient, we can build a competence toolbox saying we assess the readiness to change lifestyle. We bring it together with digital tools. We call it risk stratification. And now we have available 100 apps and 100 interventions on the market for this patient. The analysis of this data will tell us which of these tools will be the right one for our patient. And I think here is an example where digitalization will make our life much, much easier to help the patient to improve. This is an example from our COVID-19 experiences, how to use digital care in a stepwise guided procedure. If you have a lockdown situation or pandemic situation, to reach our patients at home, to work with our patient using digital tools at home. You can find this at this reference, because I think smart health, it's the final topic of digitalization, will be disruptive. This could be as digital education for our patients. So having a comprehensive digital diabetes education program, which is following the daily behavior of the patient, which is following the need of the patient, and is done purely digital. It can mean that we have to address the aspect of accessibility and acceptance in a different way. This is an analysis we have done with one of the apps developed by us, and the patient ranked 61% of quality of the app, not because of risk aspect, because of gamification aspect. So they liked it because they could play with it, and this defined adherence. And the patient is saying us what they expect from an app, from a social health profile. And if you want to go deeper into this and use this diagram to assess different products, we have here one example. It's Diabetes M. It's a standard diabetes app. It could be one of the apps from the previous presentation. And if you look at the social health profile of this app, it gives you an example. If you go to another app, it's one app we have developed for diabetes prevention in Germany. It gives you a totally different profile. So these are social qualities, social aspects for ranking an app. And if you go to the app, which I just have mentioned with the colors, we get again a totally different profile. So there are different social qualities and profiles of the different apps, and each of them is applicable to a different stereotype of patient. And this is the new future of diabetes care, of qualitative and innovative diabetes care, that we have this in mind. So one app addressing these qualities, the next one other aspects, the third one those aspects, and this can be 3 totally different patients. So if we look at these examples, what I just have mentioned, this one app, Anchor Steps for prevention, another prevention app we have developed in Germany. It's a success story by working together between universities and private companies to launch this and to make it available for a cheap price to our patient. And what was driving us? We asked our patients what they want. And then we looked at the different stages of readiness to change lifestyle, like motivation, action, maintenance. And we ranked this quality of features what an app should have based on this need of the patient. But we went ahead and said, okay, morbidity is also driving quality. And we sorted the features again following this. And then finally, based on addressing intuitive needs of our patient, social support for performance and costs. And this at the end turned it into a profile of a digital tool which really can support our patient. And the optimal diabetes prevention app, in my mind, would include all these features which are written down here. This app doesn't exist, but maybe in the future, driven by the power of the pandemic, there is a lot of energy to develop new tools. The future of health, in my mind, will be not addressing glucose. It will be addressing a behavior change for our patients. And at the end, if you are interested to hear more about this, we have developed at our university an online diabetes education program for healthcare professionals. It's called Onitpo, and we are launching this together with Ascensia. But the program was totally independent, developed by our university. And you can go to this website or using this QR code, and you get this program totally free. There's no charging for this program because we want to have a program with no barrier of accessibility. You get an access code, and so only your access code is seeable to us. And you can go through a program which was, as I said, independently developed by experts. It's accessible by any digital tools you can have. It covers the whole range of diabetes knowledge, including COVID pandemic, including digitalization. And if you go through, you get a certificate from our university. So this is the description of each of the modules, like a digitalization module. You find some slides, you find the video, you find at the end some CME questions. It looks like this, what I have shown you, and you find some of the slides from my presentation again in this online portal, and you always will get back a very practical recommendation for your daily work. There are 32 modules of diabetes knowledge. It takes about 45 minutes to attend one of these modules, and it's covering the complete spectrum of diabetes knowledge. And if you pass 21 modules, you get a certificate. This is a QR code. If you are interested, you can register there, then you get an access code, and then you can participate in this program free of cost. There's no association with any commercial activities from a company, even if we are working together with Ascensia to scale up this program. So my final message, let's work together. You in India, you have totally different experience than we have, but 90% of our experience are probably very, very common and very similar. And if we learn from each other, if we work together, then we are finally available or able to walk away from diabetes. Thank you very much. It's a great honor to speak here. Thank you very much for your attention.